So welcome everybody. Thank you for joining us for this community update to look at the threats to healthcare that are currently facing us. This is Nana Khanna with Positive Women's Network. I want to first of all thank this amazing group of organizations for coming together really quickly to pull together, sort of a real quick last minute webinar to update the community on what's been going on. I know that folks heard last week there were these a couple of threats facing us on healthcare. Just when we thought we had defeated zombie Trump care for like the 4th or 5th or 6th time, here we are again with an executive order and some additional actions by the president to undermine cost sharing. And so we realized that there was a lot of anxiety in the community about this and a lot of questions about how to interpret the potential impact and projected impacts of these executive actions. And so this group of organizations was really awesome. AIDS United, AIDS Alabama, AIDS Foundation of Chicago, and Treatment Access Expansion Project in saying, hey, we're willing to collaborate on a webinar to update the community about what we know. We don't know everything yet because things are still being figured out, but we want to share with you kind of our best assessment of where things are right now and have an opportunity for the community to ask questions of these panelists and presenters who really are incredible experts and are kind of examining these issues very precisely. So all participants are muted right now. If you want to ask questions along the way, there is a Q&A function. There's also a chat function. So feel free to, type anything into those boxes. If you go up to the top of your screen, you should see a little thing that says Q&A. You can write anything in there. Also, if you go to more, you should see a way to join the chat box and open up that box. Without further ado, I'm going to go ahead and turn this over to our first presenter, Marianne Tomazik from Treatment Access Expansion Project. And we're going to take a quick minute here to switch slides on our screen. But before we do that, let me just show you the agenda for this webinar. We're going to go through, we just did our welcome. We're going to have a little overview of the changes from Marianne from the Treatment Access Expansion Project. And we're going to look at 3 states and kind of look at what is the projected impact of these changes. What is the best guess by experts working on these issues in 3 states. So we're going to look at Massachusetts, Alabama, and Illinois to kind of give you a flavor of 3 really different state environments when it comes to, Massachusetts, a state that basically implemented healthcare reform way before the rest of the country. Alabama, a state in the South that's contending with a particular set of challenges, including around Medicaid, and then Illinois, a Midwestern state. These lessons may or may not apply to your state, but we think that many of them will be relevant and will give you some things to think about when you're considering how this may play out in your own state. And then Bill McCall from AIDS United is going to talk a little bit about what we can do to take action, both at the federal level and then in terms of in-district organizing. And we have some ideas for you. We also want to hear your ideas, and this is going to be an ongoing process that we'll all be engaging in together. So then we'll have some time for Q&A, and then we will close. So I'm going to go ahead and turn this over to Marianne to walk us through an overview of the changes, what we know, and then Marianne's also going to give us a look into Massachusetts.
Thank you, Nana. I am going to share my PowerPoint shortly. Hello, everyone. My name is Marianne Tomazik, and I'm with the Treatment Access Expansion Project. I'm going to first do an overview of some of the changes that have happened in the past week. I will make the caveat that about 1 minute ago, it was reported online that Senators Alexander and Murray had reached a bipartisan ACA deal. This is not reflective of that, but I guess this just goes along with the theme that things change every single minute around here. So this presentation is pre a bipartisan ACA deal that's been announced, and more information will come out about that over the next couple of days. So in the overview, I'm going to be talking about two recent actions from the administration. The first is the executive order titled Promoting Healthcare Choice and Competition Across the United States. The executive order did directed agencies in three different directions. We'll focus on the first two, the expansion of association health plans and expansion of short-term insurance plans because they have the biggest effect as we can predict. And then I'll also talk about the White House statement regarding cost-sharing reduction reimbursement, and then discuss some of the reactions that have been seen both in court and in various states. So association health plans are plans that allow small businesses to band across state lines and leverage their buying power so that they can buy coverage as one large group. This allows small businesses in one state, if they're banded together across state lines, to actually buy and offer insurance in a different state. Prior to the Affordable Care Act, these plans were not subject to any major federal health benefit mandates. So folks could go shopping among the different states and pick insurance in a state that had less benefit mandates. When the ACA was passed, it did not provide a specific exemption for association health plans. So many of these plans were subject to the protections that the ACA mandated. So currently, in order to become exempt from the ACA, these plans have to meet certain criteria in the Employment Retirement Income Security Act, also known as ERISA. Generally, the Department of Labor has provided narrow interpretation of this criteria, examining how well the association works as a group, how much, say, small business members have in association actions. And so there weren't many groups, associations that fell within this exemption. So in terms of the executive order, President Trump has directed the Department of Labor to reconsider the way it interprets the ERISA criteria. A second directive in the executive order was to expand the sale and use of short-term insurance. Currently, short-term insurance is used as coverage whenever you have a temporary gap. So for example, if you miss the open enrollment period and don't have insurance, you could get short-term insurance before you had a special qualifying event or were able to get some other type of coverage. These plans are not subject to the ACA standards because they're not considered minimum essential coverage. So they don't necessarily have to cover everyone who applies, and they don't have to cover every single mandate, every single essential health benefit that's mandated within a state. The Departments of Treasury, Labor, and Health and Human Services have finalized regulations under the Obama administration restricting these plans so that they couldn't be used as primary coverage. What they have found is that people who did not enroll in insurance through the marketplace were using short-term insurance and renewing it so that it would take place of primary coverage. So some of the restrictions that were finalized included limiting the term of coverage inclusive of any renewal periods that could occur, and also making these plans include a prominent statement indicating that the plan did not satisfy the requirements of minimal essential coverage. So both of these directives will have a generally bad effect on consumers. For one, the association health plans are not supported by the National Association of Insurance Commissioners, primarily because they allow small businesses to pick and choose which state regulator they'll be subject to. And also, state insurance commissioners are not fans of these plans because it makes enforcement difficult. One state insurance commissioner may be in a bind when they come to enforce another state's regulations. These plans can also compromise consumer protections by allowing businesses to buy insurance in other states with lesser mandates. So if you, for example, work in New York is a state that has a mandate for certain autism services, your employer could buy insurance in a different state that didn't have that mandate. And this can be very confusing for consumers. Additionally, because short-term insurance plans do not have to follow certain ACA standards, any expansion of this type of plan would increase the plan options for people that don't involve certain protections like essential health benefits and guarantee issue. Overall, the expansion of both of these plan types are going to have a destabilizing effect on state risk pools, because without having to comply with ACA standards and not having to provide certain mandated benefits, they can sell these bare bones plans at cheaper prices and attract the healthiest of consumers out of the state risk pools and destabilizing the state markets. On Thursday, the White House also released an announcement saying that they were going to end reimbursements for cost-sharing reductions. These cost-sharing reductions help lower co-pays, co-insurance, deductibles, and other out-of-pocket costs for enrollees that are within 100 and 250% of the federal poverty level, but only if they enroll in silver level plans. Insurers have to provide these reductions, and typically the federal government has reimbursed insurers. This is a big chunk of the marketplace enrollees. Overall in the United States, approximately 57% of the marketplace enrollees use cost-sharing reductions. And if you look at this map up on the screen, you can see that in states such as in the South, that they have a larger percentage of their marketplace enrollees using cost-sharing reduction. We had received a question during registration about CBO analysis on some of these administrative actions. In August, the CBO did release a report on the likely effects of ending cost-sharing reduction payments and estimated and predicted certain effects, including that insurers would withdraw from or fail to sell plans in the state marketplaces because they wouldn't be receiving these reimbursements from the federal government to provide plans at a low cost. They also predicted that insurers that do stay in state marketplaces would likely raise premiums in order to cover the reimbursements that they would not get from the federal government, so that they could still provide a silver level plan with the reduced out-of-pocket costs. They would just offset that with a higher premium. And because the federal government is providing premium tax credits, if the premiums on these plans are increasing, the federal government will be responsible for paying higher premium tax credits. So the CBO predicted that this would increase the federal deficit from 2017 through 2026 by $194 billion. So there have been some reactions to the cost-sharing reduction announcement. On Friday, the attorneys general from 19 jurisdictions filed a lawsuit in the District of Northern California. We did receive some questions at registration about the likelihood on whether there would be a preliminary injunction or not. The case has yet to be assigned a judge, so a lot of the predictions on this lawsuit will be dependent on which judge gets assigned and their general outlook. So that's a question to be seen. Previously, some states had anticipated a cost-sharing reduction and to payments. So they had insurers file multiple rates based on each scenario. So they would ask, what would be your rate filing if cost-sharing reduction reimbursements continued, and what would be your rate if cost-sharing reduction reimbursements ended. Some insurers also anticipated the end of this reimbursement and thus inflated the rate filing. So some folks have seen a greater increase in rates for silver level plans than in past years. And it's also likely that further down the road that other parties might bring lawsuits based on this announcement including insurers who have been expecting these reimbursements as well. So I'm going to go ahead and talk about the projected impact, specifically looking at Massachusetts. Massachusetts estimates that the end of cost-sharing reimbursements would be a $146 million loss for insurers in Massachusetts. When there was uncertainty around whether insurers would be able to get reimbursed, the Health Connector, our exchange, and our division of insurance asked issuers to file 2 rates, one assuming the status quo and one factoring in the likelihood that reimbursements might stop. In September, our state issued a 1332 waiver to set up a premium stabilization fund in lieu of CSRs, and they asked for expedited review, but has not received an answer yet from the administration. On Thursday, ironically, prior to the announcement, our state had announced that they were going to use the lower rates, assuming that federal CSR reimbursements would continue. However, post-announcement, they've announced that they're looking into various contingency plans, and it's possible that they may go with the higher rates. Our governor announced yesterday that his focus is looking short-term from now until the end of the year, and possibly looking within the state for a fix, but has reaffirmed his intent to advocate federally for CSR reimbursements from January 2018 and beyond. I'm going to return the slide deck over to Nana, and we can continue on with the projected impact in other states. Nana?
Great, thank you. So I think you just need to stop your screen share, and then I can, transition over to mine. Perfect. So while we're doing that, while I'm transitioning, we did have a question come up about what is the impact on people who buy their own insurance on the health exchanges. This is a small group, 6.7 million, but seems like they may be the most impacted early. So Marianne, I don't know if that's something you could speak to.
Sorry, I had a mute on. Could you repeat the question?
Sure. The question was, and either Marianne or any of the other panelists, can you talk about the impact on people who buy their own insurance on the health exchanges? This is a small group, 6.7 million, but seems like they will be most impacted early.
Right. So I think we might see the biggest impact on people who buy silver level plans, but do not qualify for premium tax credits or cost sharing reductions. Simply because for those who do qualify for cost sharing reductions, if the premiums increase, they're still eligible for tax credits that help make those plans affordable. But for people who don't qualify for the tax credits, they might be responsible for paying the inflated cost of a silver level plan. I think even if we look away from CSRs, people who buy insurance on health exchanges will also get impacted by the executive order, because the healthiest of consumers, people who don't expect to use the healthcare system, will be drawn away from the state exchanges, and insurers will for sure incorporate that into their new rate filings next year, and we'll see prices increase.
Okay, great. Thank you so much, Marianne. I'm going to go ahead and turn over to Matthew from AIDS Alabama, who's going to be talking about the situation, the projected situation in Alabama, and as it may be applicable to other states in the South as well.
Thanks, Nana, and good afternoon, everyone. So I'm going to first kind of give us a lay of the land, so to speak, and provide some regional context on healthcare access and a 5,000-foot view of the marketplaces in the Southeast. and then talk a little bit about what the marketplace looks like in Alabama, and then go from there into the statewide impact for us here in Alabama, and share a bit about what that would look like in general across the region, and maybe how we're expecting that impact to play out long term. So next slide. So I always think it's really important to lift up and highlight that when we're talking about addressing the HIV epidemic, the South is the current epicenter of our epidemic here. In 2015, the states in the Southeast were home to over half of all new HIV diagnoses, to 51% actually, and over half, 52% of all people living with HIV who are unaware of their HIV infection and their status live in the South, according to CDC estimates. The South also, because of some of these policy barriers I'll get into here in a second, consistently has higher rates of HIV-related deaths and worse health outcomes for folks who are living with HIV, such as engagement and adherence to treatment. And so pretty critical to make sure that we have healthcare access everywhere, of course, in the US, but the barriers in the South are particularly high. One of those barriers being policy related. Many of the states in the South, as you can see from that bottom map, have not expanded Medicaid. Louisiana recently joined that train, so that's great. Hopefully that trend continues, but until then, this has put a pretty heavy burden on the marketplaces in the states in the Southeast, because it means that in states that have expanded Medicaid, folks who would normally qualify then for the Medicaid program would be covered under that state program instead of the marketplaces. So marketplaces in states without expanded Medicaid, the insurers are paying more for more health services because there are a lot more folks who would otherwise have been under the Medicaid programs that are now getting insurance either through the marketplace. There also, as you can see from that map, in the middle there, the Southeast is also a hub for economic inequality and experiences disproportionately higher rates of poverty, particularly in rural communities and communities of color. And also states in the Southeast tend to be more rural than in other regions. And we know that typically in rural communities there are usually less options around healthcare providers and facilities. And then I'll talk about this kind of towards the end around impact, but we'll see that many rural communities in the Southeast are also the ones experiencing some of the insurer provider losses or at greater threat of that. Next slide. So as Marianne mentioned earlier, the Southeast, because of the economic inequality and lack of Medicaid expansion, as I mentioned earlier, takes in the largest share of the CSRs and premium tax credits. CSRs is the map on y'all's left, and the premium tax credits on the right. So within the Southeast, and particularly the states in the Deep South, at least 60% of the marketplace enrollees receive the cost sharing reduction benefits, and then it's even particularly higher for Deep South states for percentages of enrollees who receive the premium tax credits, which help bring down those plan costs and premiums that otherwise would be pretty significantly higher because the insurers are kind of eating these costs from the lack of Medicaid expansion. Next slide. So in Alabama, in the 2017 QHP open enrollment had over 170,000 enrollees. As with many states in the Southeast, as I mentioned, a fairly large share, over 3/4, receive CSRs. In most states, I think nationally and especially in the Southeast, most enrollees are on silver plans and then do qualify within that CSR range. And that works out to about an average of greater than $1,200 annually that they receive. And above and beyond that, almost all marketplace enrollees in the individual marketplace in Alabama receive premium tax credits, and that works out to greater than $3,700 for each person annually. So all of that kind of works together to mean that the out-of-pocket costs for Alabamians in the marketplace is kept pretty low comparatively. It's roughly $110 a month. And for many folks, it's actually substantially lower than that because of the combined effect of the CSRs and premium tax credits. Now, the other kind of big thing to remember for the marketplace in Alabama, we have had a loss of insurers on the individual marketplace, and Blue Cross Blue Shield is now our only remaining insurer statewide. They actually assumed pretty early on that the CSRs would not continue, and in summer announced that they were applying for premium increases on the silver level plans that average about 16%, but can be as high as a little over 20% for some of them, and then applied for about 2 to 5% premium increases for all the other metal level plans. Next slide. So looking at the initial impact in the state, it's going to be actually pretty blunted because of those high level of premium tax credit enrollees. So as Mary mentioned earlier, folks that would be receiving the CSRs will have that the increase in premiums kind of blunted by the premium tax credits, which will also increase based on the premiums of the silver level plans, since those are the benchmarks for the marketplace. And that will probably make up the difference for most enrollees initially, though there will, as I mentioned, be a small percentage who do not qualify for premium tax credits that would then, but have silver level plans and then would see that increased premium, but not get afforded reductions and assistance. In addition, the premium hikes could discourage younger and healthier enrollees from those plans or from the marketplace in general. And the other executive orders, depending on how they roll out, as Marianne also mentioned, could contribute to that as well. And while we're not seeing too high of premium increases compared to some other states with Blue Cross, this could be a cycle that, looking down the road, would further create instability with the marketplace and lead to some even more substantial rate increases. In the past, Blue Cross has had premium increases of at least 30% the previous year, which could be substantially higher, and there's not necessarily a reason that going forward they wouldn't then distribute that to some of the other metal level plans versus just silver. And then another important factor to consider for Alabama, like many states, our ADAP program purchases insurance plans for enrollees to help provide insurance coverage completion. We currently purchase gold plans since Blue Cross discontinued their platinum level. And as I mentioned before, while the gold plans are not going to see a large rate increase, any rate increase still eats into the very thin funds from that the state provides and it takes away funding that otherwise could go to completing more coverage for more people living with HIV. And should we see an increase in premiums going forward from further instability or loss in the marketplace or losses that Blue Cross may take and then put back onto consumers, that could potentially be even larger chunks that would then go into purchasing those plans should the gold plan see larger premium increases as well. So something we're gonna have to keep our eye on there for sure. Next slide. Across the region, it's kind of fairly similar impact. Many of the other states in the Southeast, as I mentioned before, also have high percentages enrollees who would be receiving the premium tax credits that would kind of blunt these premium hikes. And there's a really cool resource called Balloon Juice with some public health policy wonks who've been putting together a map that they've been updating and some spreadsheets to try to see what the different state strategies around the CSRs have been. And so if you check that out, you can see that in the Southeast, most of the states had already assumed the CSRs would not continue, and the insurers are using what's called the silver loading strategy. So what I mentioned for Blue Cross, basically putting most of the premium increases to cover the losses from the lack of CSRs onto those silver plans. And this actually does create a weird opportunity for some folks that would have been getting CSRs and also are getting premium tax credits to maybe switch to some gold level plans that would weirdly be cheaper initially than the silver plans. But is at least maintaining for now the premium increases within silver. We have also seen in the South a large amount of reduction in insurers. And even this year, Mississippi and Georgia especially are seeing insurers pull out from a lot of their counties, particularly in rural areas. There are many states in the Southeast that have only one insurer covering, or have only one insurer left in many parts of the state. And while we don't expect here in Alabama Blue Cross to pull out, since they are fairly large and have a pretty solid presence in the state, and while so far there has yet to be an instance where there have been no counties covered, additional pressure could change that for many states, and without options and competitive pressure in the marketplace, it could just fuel the continue to fuel these higher premiums and make it harder to put pressure on insurers to provide more affordable plans. So that's something else that could be pretty worrisome going forward in the region. And the last item to think about for the region for impact, looking further down the road, as Marianne mentioned, because the premium tax credits are going to be taking more hits from this, that could increase federal deficits, or will likely increase federal deficits by a significant chunk. And we know that could just empower deficit hawks at the federal level and dissuade further funding for domestic programs, or see even maybe more severe caps put in place, or power arguments around that. And all of that could threaten federal funding for programs for people living with HIV, which impacts nationally the country, and particularly would impact southern states that already have very strict and limited funds for public health programs. All right. And that's all that I have in kind of a quick 5,000-foot view of what the impact I think would be in the Southeast.
Great. Thank you so much, Matthew. That was really very helpful. So just a reminder that folks are welcome to put questions in the chat box as we're going along. We'll also have a Q&A later where we can open up lines for people who want to ask questions verbally. But I'm just going to keep it moving for now. And so our next fabulous presenter is Elena Kennedy from AIDS Foundation of Chicago, who's going to be talking about standing up to the sabotage in Illinois and the Midwest. Elena, I'm turning it over to you.
Wonderful. Thank you, and hello. Thank you for having me. Next slide. So as we've been talking about, Trump raised insurance rates essentially, but Republicans are taking deliberate action to sabotage the healthcare. Specifically, I will be talking about Illinois. That's where my expertise lies, but I will at times be talking about the Midwest, and there is some overlap that is happening. For example, Midwest states, including Illinois, Indiana, Michigan, and Ohio, attribute rate increases to the uncertainty over whether the Trump administration would make those cost-sharing rate payments. We've heard of that across the country as well, so this is very consistent. In general, what a lot of the departments are saying is due to the uncertainty, they have had to react in certain ways, and we will continue to talk about this further as we go through the slides. One state, though, in particular that I would like to make mention, Minnesota, mostly cut their insurance rates next year after federal government allowed them to start a new reinsurance program. For the purposes of this webinar, I won't be getting into that, but a lot of that was discussed through the bipartisan efforts that Senator Lamar Alexander and Senator Murray were having in their committee. And this idea about having these bipartisan discussions and debates should continue. Just a call to action for that. But moving along, next slide. So what's happening now? As we've continued to talk, the Trump administration took 2 actions last week, one with the executive order, which creates a loophole for group and individuals to buy skimpier health plans, essentially, and then the ending of the CSRs for insurance market plans. Now, insurers in Illinois assumed CSRs would be cut in their 2018 proposals for marketplace rates, which is why they increased their silver level plan premiums, which is consistent with what we've heard in some other states. So we don't think moving forward anything will change. These have already been set and there will not be adjustments. Now, Illinois' largest insurer, Blue Cross Blue Shield of Illinois, said on Friday, October 13th, it plans to remain on the exchange next year and is already took into account the possible end of subsidies when it filed rates next year. Also, the Health Alliance Medical Plans, which offers exchange plans mostly in central and southern Illinois, said it also took uncertainty surrounding the subsidies into account when setting the 2018 rates. And as I've mentioned, that is because the Illinois Department of Insurance Director Jennifer Hammer said insurers have been advised to apply the CSR uncertainty costs solely to their silver plans. She actually went further in saying the Department of Insurance is committed to ensuring that consumers are prevented from incurring higher health insurance costs due to the uncertainty in Washington. What that all comes to means is that Illinois assumed these cuts, and the one thing that's important to keep in mind, though, is that those who receive tax credits will be sheltered from the premium increases. Those who do not get premium tax credits, middle and upper income families, so about 97,000 for a family of 4, will feel the brunt of these increases, which is problematic. Next slide. In Illinois, more than 350,000 people are enrolled in health insurance through our exchange, which is fantastic. About 175 of those consumers benefit from the cost-sharing reductions. So those other remaining people will feel the brunt of this increased insurance rate and premium increases. Like I said, it's problematic. The ACA has been transformative for people living with HIV in Illinois specifically. Nearly 3,000 people with HIV gained coverage through the health insurance marketplace and had premiums and out-of-pocket costs paid for by the AIDS Drug Assistance Program, ADAP. Next slide, please. One thing I did also want to say that when selecting a plan, though, remember that the cost of your premium is not the only thing you should factor in when selecting a plan. It is important to take a look at your financial health, your doctors, hospitals, premiums, copays, and deductibles, and factor those into the prices. So these changes that are happening are important for consumers, but what it also means is they need to be very diligent when they shop for plans this year. The Department of Insurance and other leaders, as well as our organization, reminds consumers that cost alone may not be the only factor. For example, consumers may want to also look to see if their plan's provider is a network, if their medications are, what even the cost sharing of those medications is. There high copays or deductibles, what's the cost sharing? Is there prior authorization? These are also other important things to keep in mind. And I just want to keep on everyone's the forefront of the conversation as we continue and near this open enrollment period. Next slide. One thing I also want to address is that we will be doing plan assessments. In years previous, AFC has reviewed the insurance plans on the Illinois marketplace, and we will continue to do so. The assessments are intended to be used to guide people through their health selection plan. So I also encourage people in the Midwest across the country to to look into if other ASOs are doing plan assessments or national partners, like I know NASA and other programs are doing so to ensure the best plans are selected. You can also reach out to plan coordinators and ask for guidance with navigators as you guide through the process. Next slide. Ultimately, though, as I want to say, experts warned that the failure to make these payments would raise premiums by 20% or more and add nearly $200 billion to the national debt. Even Republican Senator Lamar Alexander of Tennessee warned without payments of these cost-sharing reductions, Americans will be hurt. And in these bipartisan discussions that were happening, we heard that over and over from different departments of insurance and other advocates across the country. And Trump has been cheerleading the sabotage for months, saying earlier this year, the best thing we can do is let Obamacare explode and let it be a disaster because we can blame it on the Democrats. Honestly, at this point, the clearest evidence, though, is the Trump administration is sabotaging our healthcare system and leading these higher insurance rates, as we've been seeing. And so there is this call to action and to be informed. So thank you once again for having this webinar and partaking. If you would like to get more informed, though, next slide. And get more information, though, here in Illinois, you can sign up for Protect Our Care Illinois. Protect Our Care Illinois il.org is our website. You can also follow us on Twitter and Facebook. And we'll be having more information coming out about these sabotaging efforts that are happening in Illinois. AFC website will also be helping with the enrollment process as well. And it's important to remember that open enrollment is happening. ACA is the law of the land, and there is access as well. So thank you so much for listening today.
Great. Thank you so much, Elena. So we are going to do a quick slide switch here and try to get Bill's slides up. So Bill McCall from AIDS United is going to be talking to us about what we can do, taking action on some of these issues. And so as I'm switching over to the slides, though, I just want to flag that we had some questions come up in the chat box about what is the timeline when people will actually start to feel the impacts of these different actions. And I think the timelines are a bit different for the executive order and for the CSR issue. So I'm wondering if any of the panelists could speak to sort of both of those projected timelines.
This is Marianne. I can talk about the executive order. So I mentioned in the chat box that the executive order largely depends on how fast or how slow the Departments of Labor, Treasury, and Health and Human Services act. The executive order simply directed them to consider revising certain rules and guidance. So it will largely depend on whether these departments do consider and how fast they do. But certainly before they can act, they need to consider public comment, which means that announcements would come out in the Federal Register and would leave open a comment period where advocates and other stakeholders can submit public comment on the proposed rules. So for the executive order, there is some time both for the impact to ultimately be felt, and also time for advocacy as well. For the CSR reimbursements, that seems to be a little bit more state by state, simply because the marketplaces are run differently, as you've heard in the past three presenters speak.
Great, thank you so much. I'm going to go ahead and turn this over to Bill. Bill, are you seeing your slides?
I'm not seeing my slides, but that's okay because I know what's on them and I can just talk about it.
Well,
I also wanted to go on ahead as well, and oh, there they are. Yeah, wow, that's really impressive. Thank you so much, Nana.
No problem.
Appreciate that. So I'm going to just real quickly note that just even as we literally got onto the phone, news came through about the deal. It's already been mentioned between Senator Lamar Alexander from Tennessee and Patty Murray from Washington. They are the chair and the ranking member of the Health, Education, Labor, and Pensions Committee, and they've apparently reached a deal that would provide funding for cost-sharing reduction that would stabilize health insurance markets. It's being reported by the New York Times that the subsidies would be funded for 2 years, which would give some short-term certainty to the insurers. And then there's a couple of other things that we've been hearing. In particular, it's been reported that there would be quote-unquote meaningful flexibility, meaning that I think that the states would have an ability to make changes to their insurance markets in a way that conservatives have been concerned. What we do also know is that there's literally no guarantee from leadership on a vote yet. So basically Alexander and Murray are going to go out and go get co-sponsors and then present it to McConnell, Senator Mitch McConnell from Kentucky, who's the majority leader, and Chuck Schumer, who's the Democratic leader. And then a couple of other things that we had heard from earlier. So put this in more of the rumor mill because I haven't actually seen the deal, but supposedly the deal would also require more transparency, boost consumer-driven health plans, expand insurance options, delay the employer mandate, and then require plans to lower premiums that increase due to the CSRs. So that is what we've heard. It's a lot of it's hearsay, and so we'll see what happens. So next slide. We've already talked a little bit. So what I want to do is to help folks figure out what it is that that they can do as advocates and to kind of keep the ACA rolling, protecting it from sabotage. So the first thing is we've talked quite a bit about the regulatory actions. So one of the things that will happen is that each of the agencies that deal with the issues in the executive order have to put forward proposed rules changes. Those will come out in the Federal Register. And what I would encourage people to do is to stay in tune with the national organizations such as, or actually local and regional organizations as well, such as PWN USA, and of course I have to say AIDS United, to know when those rules are coming out, to also learn what the things are that to also learn what needs to be said, or what any concerns are that are created by the new regulations, and how and where to send letters. And a lot of times it is very helpful to send in as many letters as possible. So we definitely encourage people to look for those opportunities, and certainly we'll be getting that information out. Almost certainly, the Healthcare Access Working Group will also do a sign-on letter that's typically aimed at organizations. So if you work with an organization, that might be something else to keep an eye out for. So this slide kind of predates the bipartisan bill, but that bill is not even really been introduced yet. So we definitely urge folks to support bipartisan congressional efforts to stabilize the marketplace. One of the things that my boss, Ronald Johnson, has been fond of saying is that Americans' healthcare is not a bargaining chip. And I think that's a really great line to use when you're calling your members of Congress, your senators and folks in the House of Representatives to let them know. And I think keep an eye out for action alerts that emerge. Most of the HIV groups in Washington stay in touch with each other, and we typically try to reinforce action. We've also have an HIV hotline that will move folks to doing calling, and as soon as and as we get closer to some deadlines or closer to a vote, we'll make sure that that hotline is up and running, and people will be able to hear that. Keep amplifying the messaging that you're hearing. I think one of the things that is important is for people to understand just who is creating issues and why, and to ensure that there's accountability. So for folks that tweet, go on ahead and retweet. For folks that do Facebook, certainly I hope you'll amplify the information that's out there from groups. One thing I think folks could do is really get knowledgeable about enrollment. We haven't really been talking about all of the things that the administration's been doing to really knock down the number of people who are enrolled in healthcare, but they have literally limited, they've changed the dates, the deadlines for by which people have to enroll. They've shortened the enrollment period to, I think it's 30 days now. They are literally going so far as to take down the website on Sundays, quote unquote, because they believe they have to have maintenance, which is just a really transparent attempt to keep people from being able to enroll and from using their website. And so definitely get knowledgeable about enrollment, help people to enroll. We definitely urge organizations that are working primarily in the HIV field to go on ahead and just get messaging out there to communities that you're working in about these enrollment issues and deadlines and how to get enrolled. And as much as possible, if you've got patient navigators or you've got people who know how to operate the system, we urge people to just get out there and push enrollment as much as possible. One of the questions that came up prior to, from somebody who registered for this is whether advocates should be pushing their states to join the lawsuit. As was noted earlier, there are 19 states right now that are in the lawsuit. I do think that is a useful strategy, and I think that if your state is not among the ones that are in the lawsuit, pushing your attorney general to join the lawsuit would be great. And then I would also say, for those of you who are in those states, let your lawmakers know that you support their effort to sue. I think this is really important that there not be, that we not allow people to unaccountably end programs that people depend on. And then finally, we were talking yesterday with Paul Davis from Housing Works. Definitely keep an eye out looking for advocacy days in your state and in Washington, and also for grassroots actions. Certainly, I think to a large extent they really helped show the public anger about what's been happening with healthcare and all of those things. And I definitely believe that just staying active, staying vocal, getting out there and protesting, when the opportunities arise. I think that's really helpful. And getting involved with some of your local groups, whether it's Indivisible or some of the groups that are working with Housing Works or others, I definitely think that's very valuable work. So I think those are kind of the main things that I'm really suggesting folks do. Pay attention. I think I would just say that these changes aren't happening right away. There's not going to be an immediate wow, I no longer have insurance or things like that. But trying to understand what the effects are, really getting behind the bipartisan bill and pushing. We will obviously need to read the bill and understand what's in it to make sure that we are able to support. But I think that's obviously something that's going to be coming up. I think that's it, unless somebody has a question for me.
That's really great, Bill. Thank you so much. I think one other thing I would just point out and add is that this week is a congressional recess. So your members of Congress are home. This is a really good time to go pay them a visit and, express your concerns about this. Use the talking points that Bill just put out there. Our healthcare incentive partnership, we support bipartisan efforts to stabilize the marketplace, et cetera. So there's a question that came in about association health plans from Kevin Lish. The question is, would AHPs, that's association health plans, be allowed to file in a state with consumer protections and then basically sell across state lines without filing in those states? Does anybody do any of the panelists want to address that?
Just real quickly, can I say, one, if you don't mind, can you advance the slide one more time just so that folks have that last slide that we've got? And then I just want to mention that it's actually the House that's out of session. The Senate is actually in session right now, so they won't be back. But anyway, do take those opportunities. I apologize. I just wanted to note that.
Great.
And I'm probably not the best person to answer the question about the AHPs.
Okay.
This is Marianne. I can respond to that question. Expanding association health plans and the marketability will likely result in associations being able to shop around, but it largely depends on what kind of guidance and regulations come from this executive order. It certainly seems like it's going to go into that direction. State officials do have very serious concerns about how increasing the availability of these plans will affect their markets and, of course, their ability to enforce not only their own state regulations and questions around how they can enforce a different state's regulations. I will post a helpful handout from the National Association of Insurance Commissioners that might be helpful in your advocacy or for general understanding of the issue.
Great, thank you so much. There's another question that came out in the chat box. Bill, I think you already addressed it. The question is, will there be template comments for folks to submit basically on the proposed rules and regulations?
Yeah, so I think what we'll do is we'll definitely have a template letter that people will be able to use. There might be a sign-on letter, and then I think to the extent that we feel like there needs to be like bullets or things that people can pick and choose from, we'll get that out there. But we'll definitely make sure that people have access and that people know what the deadlines are and how to submit letters for the record.
Great. Thank you so much. I think we have time for maybe one more question. Okay, it looks like there's a question here from Sean McShee regarding association health plans. Health insurance networks have to be local. How would multi-state health insurance plans facilitate local networks? And Sean, I don't know exactly what you mean by facilitate. I don't know if you want to clarify that question.
Can you read that again, actually?
Sure. Association health plans, health insurance networks have to be local. How would multi-state health insurance plans facilitate local networks?
So I think one of the things with the association health plans is actually that they can be multi-state and that they're basically able to transcend those borders. One of the issues actually is that, if you've got a narrow network or a narrow plan, even though the association might, quote unquote, have benefits, you might be out of network in the place where you're applying. And I think that's, I think one of the issues really about these plans is that in some ways they, very much limit benefits, and they could sidestep in some ways the issue of pre-existing conditions because they're not held to the same standards. So we've referred to a lot of these types of plans as junk insurance plans. And so that's one of the concerns that we really have.
Great, thank you. So let me see if folks are now seeing the other slide deck. We just wanted to give you a place you can go for more information. So thank you everybody so much for joining us. A huge thank you to our presenters for pulling this together really quickly. We realize that there are still lots of questions and things to be determined out there. And I think, you know, part of the issue with the CSRs in particular is that it will be such a state-by-state situation. This whole scenario is really evolving. As we saw, you know, even while we were on this call today, a new bipartisan piece of legislation is potentially being introduced. So, and then with the CSRs, we also know that some states already sort of built that into their planning. So this really is kind of an evolving and dynamic situation, and please stay tuned. We're going to make the recording available on the PWN USA website, which I probably should have put on here, but it's just pwn-usa.org. We'll also send it out to all of you, a recording along with the slides from this webinar. And if you have, you know, additional questions, thoughts, ideas, please feel free to get in touch with us. Do any of our panelists want to make any closing comments before we close out today?
Nana, this is Bill. You know, I know that one of the questions that actually came up, and I'm not sure got addressed from folks that were coming into the, or prior to the beginning, was how will this affect Ryan White funding? Mm-hmm. And I did want to just say, I think that, because I know that's an issue that people really worry about. And I just want to say that I think that in terms of appropriations, I don't really expect these types of things to really affect the Ryan White program funding directly. But what might happen is if people begin to fall out of care or the prices rise, that might impact you know, the state's spending of the Ryan White program. So maybe an ADAP needs to spend more money getting insurance, or you know, those kinds of, you know, those kinds of things will have an impact. But I don't actually expect it to impact, at least in Washington, the amount of funding specifically being provided to the Ryan White program.
Great, thank you. Yeah, I think that was a really important question to address. Okay, any other final comments from our panelists? Thank you all. Oh, go ahead.
Oh, sorry. So this is Matt. I just wanted to echo and lift up for folks to just stay vigilant, and kind of highlighting that a lot of this is unfortunately a little bit of a wait and see, and kind of reacting on our feet to the different changes that happen. But to stay vigilant, and then really encourage the folks who are on this webinar to help kind of spread the word about you know, in open enrollment, and getting folks involved and engaged on these issues, and say, hey, you know, it's important to follow along what's happening, let your friends and neighbors know, and get them involved and engaged and taking action on all these issues as well.
Mm-hmm. That's great, thank you. And I really want to encourage folks to, you know, all the organizations that co-sponsor this webinar are consistently producing new resources, or sort of sharing information as we get it. And trying to mobilize folks to take action as well. So please check out the websites for all the organizations that were part of this webinar, sign up on their mailing list. That's the best way to get timely information. Follow them on social media, because a lot of stuff is going to be disseminated there sort of as it's being announced or changing in real time. So thank you all again. Huge thank you to all the organizations that came together for this, and we will talk to you all soon. Hang in there, everybody. This is going to be a long fight, and we can do this. Thanks, everyone.
Thank you, Dana. Bye-bye.
Bye.
Thanks all. Bye, everyone.